Hello everyone, I am Dr. Shaw Mukherjee and welcome back to my channel. Are you preparing for the upcoming FMGE and NEET PG exam and you are still struggling with pharmacology? So today I am here with an ultimate rapid revision video for pharmacology, which is simplified, focused and tailored for your upcoming exams. Now, in the final days of your exam, smart revision matters more than your thick notes. So today I am here with 6 pages high-yield rapid revision for pharmacology, which will cover all the important points for your upcoming exam and also the most probable questions. So 6 pages, one subject, full marks. Let's begin. And also don't forget to subscribe to my channel. If you find this video helpful, please comment down your feedback, and in the comment section the link for the notes is also given. You can download the notes from there and you can join my Telegram study group, which will help you benefit for your upcoming FMG and NEET PG exam. So let's begin.
So our first topic is autonomic nervous system. Now, in autonomic nervous system, we have to learn about the anti-glaucoma drugs. So what are the anti-glaucoma drugs? Now, how will the patient present to you? The patient will present to you with increased intraocular pressure. Why? Why the intraocular pressure increases? Due to increased aqueous humor. Now, what we have to do with the drugs? We have to maintain two things. We have to either increase the drainage or we have to decrease the synthesis of aqueous humor. So how we can increase the drainage? Drainage is of two types, trabecular drainage and avuloscleral drainage. So for trabecular drainage, we will give the drug pilocarpine, and it is the drug of choice for acute attack of angle closure glaucoma. What is the side effect for pilocarpine? It causes peripheral retinal detachment. Now, the other drainage system is avuloscleral outflow. So what drug we have to give? We have to give prostaglandin F2 alpha. We have to increase that. The drug for that is latanoprost, and what is it is the drug of choice for maintenance treatment of glaucoma. What are the side effects for this? The side effects are pigmentation of iris, inflammation which includes uveitis and keratitis, and also it increases the length of eyelashes and causes macular edema. So these are the side effects of latanoprost. So what are the drainage drugs? Pilocarpine and latanoprost, which increases the drainage of aqueous humor and thus lower the intraocular pressure. Now, coming to the synthesis, which lowers the synthesis of aqueous humor. So if the aqueous humor synthesis becomes low, the intraocular pressure ultimately becomes low. What are the drugs? Beta blocker. Example is timolol. What is the side effect of timolol? It causes bronchospasm, and the contraindications for that is in which cases we cannot give timolol. We cannot give it in bronchial asthma if the patient is a known case of bronchial asthma or COPD. What we have to give in such cases? We have to give betaxolol. It is again a beta blocker. The second group of drug is alpha-2 agonist. The example is brimonidine, and it causes, the side effect for this is it causes CNS suppression in children, and it also causes retraction of eyelid. Now the third one is carbonic anhydrase inhibitor. The example for that is acetazolamide, and the fourth drug is mannitol. So these are all the drugs by which you can decrease the aqueous humor and ultimately decrease the intraocular pressure. Now our next topic is alpha blockers. So what are the examples of alpha blockers? Prazosin, phenoxybenzamin, phentolamine and tamsulosin. Now let's see the various drugs. So for prazosin, it is the treatment for hypertension crisis due to scorpion bite. So due to scorpion bite, if there is hypertension crisis, we have to give prazosin. Now, what is the work of phenoxybenzamin? It is the drug of choice for hypertension crisis due to pheochromocytoma. Pheochromocytoma is a type of tumor. If there is hypertension crisis due to pheochromocytoma, we have to give phenoxybenzamin. Now, phentolamine. Phentolamine is the drug of choice for clonidine withdrawal syndrome. So someone is taking clonidine and suddenly the medication is stopped. So due to that, if there is withdrawal syndrome, clonidine withdrawal syndrome, it is also known as rebound hypertension crisis. For that, we can give phentolamine. Phentolamine is the drug of choice for clonidine withdrawal syndrome. It is very, very important. Now, the next one is tamsulosin. Tamsulosin is a selective alpha-1 blocker. Selective alpha-1 blocker is tamsulosin. It is the drug of choice for BPH, benign prostatic hyperplasia. So tamsulosin is the drug of choice for BPH. The side effect is floppy iris syndrome and retrograde ejaculation. It may cause floppy iris syndrome and retrograde ejaculation. Ulta. Ejaculation will be ulta. So the third group or third topic is indirectly acting cholinergics. So what are the indirectly acting cholinergics? What is the mechanism of action? It inhibits the acetylcholine esterase enzyme. So indirectly acting cholinergics inhibits the acetylcholine esterase enzyme, and therefore what happens? The acetylcholine level will increase, and it acts on muscarinic or nicotinic muscarinic receptors. By acting on these receptors, it will increase muscle contraction. So this is the function of indirectly acting cholinergics. Now it can be categorized into reversible blockers and irreversible blockers. In reversible blockers, there may be of two types. One which acts on the central nervous system, the other which acts on the periphery. So which drugs act on the central nervous system? The first one is donepezil. It is the drug of choice for Alzheimer's. And the second drug is physostigmine. It is the drug of choice for atropine poisoning. Now, the drugs which act on the periphery. So, the first one is pyridostigmine. Pyridostigmine is the drug of choice for myasthenia gravis. Then comes neostigmine. Neostigmine is used as a reversal for skeletal muscle relaxant. So, after any surgery, to withdraw the effect of skeletal muscle relaxant, we can give neostigmine. What is the other function of neostigmine? It can be used in cobra bite. So cobra bite also we can use neostigmine, but first we have to give anti-snake venom. With anti-snake venom, after that we can give neostigmine. Also, when we give neostigmine in cobra bite, we have to combine it with atropine. So this is important. We have to combine neostigmine with atropine when we give it in cobra bite. The other drug is edrophonium. What is the function of edrophonium? It is used in the diagnosis of myasthenia gravis. So diagnosis of myasthenia gravis, we use edrophonium, and drug of choice for the treatment of myasthenia gravis, we use pyridostigmine. So these two drugs are very, very important. Now coming to the irreversible blockers. So the first examples are organophosphates and carbamates. These are mainly poisons. So in organophosphate poisoning and carbamate poisoning, what we can notice, what are the clinical features? So you can remember this by the mnemonic dumbbells, DUMBELS. By this mnemonic, you can easily remember the clinical features of organophosphate and carbamate poisoning. What are the clinical features? D for diarrhea, U for urination, M for meiosis, B for bradycardia, E for epilepsis, L and S are lacrimation and salivation respectively. Now, what is the drug of choice for carbamate and organophosphate poisoning? So the drug of choice is atropine, and with atropine we have to combine any oxime. What is an example of oxime? Pralidoxime. So for organophosphate and carbamate poisoning, we can give atropine plus any oxime like pralidoxime. So our ANS topic is finished. Whatever the important main points are present in ANS, autonomic nervous system, I have covered all those points. Now let me clear one thing. This video is not for your concept clearing. If you want to study pharmacology, if you are in MBBS, you want to study full pharmacology, you must go for main videos. There are many subscriptions available. Study from those teachers. This video is only for those students who are preparing for the FMGE NEET PG exam. They need just 1 to 2 hours to revise an entire subject. For them, this video is an ideal thing because in 6 pages you can revise in just 1 hour and you are ready to go for the exam. So I am not covering all the topics, all the details here, just the important topics, all the previous year questions and the most probable questions which are about to come in the upcoming exam. Once again, notes, you can get the notes PDF. I am giving the link in the comment box. You can download it from there. Now, moving on to the respiratory system. So the first topic in respiratory system is bronchial asthma. What is the best drug for bronchial asthma for treatment? Inhalation corticosteroids. The short form is ICS. So inhalation corticosteroids we can give in bronchial asthma. It is the drug of choice. Also we can give bronchodilators. The example is formoterol. So inhalation corticosteroids plus bronchodilators. Now example of inhalation corticosteroids is budesonide, and example for bronchodilators is formoterol. What is the side effect of inhalation corticosteroids? So if we take a pump inhalation corticosteroids with our mouth directly, it can cause oral candidiasis. So how we can prevent oral candidiasis? We can prevent it by rinsing the mouth or using a spacer. So if we keep a special device between the inhalation corticosteroid and our mouth, oral candidiasis can be prevented. What is the treatment of oral candidiasis? We have to give antifungal drugs for treatment. Example is clotrimazole, miconazole and fluconazole. Clotrimazole and miconazole are local drugs, whereas fluconazole is a systemic drug. Now, what are the other drugs? Other drugs may be leukotriene receptor inhibitors. So leukotriene receptor inhibitors is, example is montelukast. You can see LU leucast and LU leukotriene. Leukotriene receptor inhibitor is montelukast. Lipooxygenase inhibitor is Diluton, and IgE inhibitor is omalizumab. So these are the other examples of drugs for bronchial asthma. Now another drug is theophylline. It is a phosphodiesterase inhibitor and it is also adenosine blocker. So its mechanism of action is it blocks adenosine. What are the side effects? The side effect, it causes sleeping problems, insomnia, tachycardia and diuresis. So if theophylline is consumed with ciprofloxacin, if it is consumed with this drug, it can inhibit the theophylline metabolism and thus it can result in theophylline toxicity inside our body. Now, Another drugs are beta 2 agonists, which are also bronchodilators. It can be divided into short-acting beta agonist and long-acting beta agonist. Long-acting beta agonist examples are formoterol and salmeterol, whereas metrol, if at the end it is metrol, it is a long-acting, and short-acting is salbutamol. What are the side effects of salbutamol? Side effects are tremors, tachycardia, hypokalemia, hypotension, and hyperglycemia. You have to keep it in mind. Only glucose level increases as a side effect of beta blockers. All other things will decrease. The heart rate will decrease, the potassium level will decrease, the blood pressure will decrease. Only the glucose level, hyperglycemia, only the glucose level will increase. Now, coming to our next chapter, which is kidney. So for kidney, what drugs we can give? We can give diuretics. The examples are carbonic anhydrase inhibitors. The name of the drug is acetazolamide. So acetazolamide is the drug of choice for acute angle closure glaucoma, and also we have to combine pilocarpine. Like pilocarpine can also be used as a drug, as a treatment for acute angle closure glaucoma, but the drug of choice is acetazolamide. Also, acetazolamide is the drug of choice for mountain sickness. So you have to keep this in mind. Now, what are the side effects of carbonic anhydrase inhibitors? It can cause metabolic acidosis. Now, the second drug is mannitol. Mannitol also you have studied in ANS. It is used for glaucoma. So it is the drug of choice for raised intracranial tension, intracranial pressure. So it is the drug of choice for raised ICT, and also it is the drug of choice for cerebral edema, and it is used in ACG, acute angle closure glaucoma. Now, what are the contraindications for mannitol? We cannot give mannitol if the patient is suffering from chronic heart failure, congestive heart failure, and pulmonary edema. Why? Because it can aggravate, it can precipitate the disease. So we cannot use, if the patient is suffering from CHF or pulmonary edema, we cannot give mannitol in that patient. We have to give some other drugs. Now, the third one is thiazides. So what is the function of thiazide? What is the mechanism of action? It blocks the sodium chloride pump. So thiazides blocks the sodium chloride pump. What is the use of this? It is the first line treatment for maintenance treatment of hypertension. For maintenance treatment of hypertension, we use thiazides, and also it is used in the treatment of hypocalcemia. It is the drug of choice for nephrogenic diabetes insipidus. For nephrogenic diabetes insipidus, it is the drug of choice. It is the first line treatment for hypertension maintenance treatment, and it is used in the treatment of hypocalcemia. Now, what is the side effect? The side effects are hyperglycemia, hyponatremia, and also erectile dysfunction. Now, coming to the fourth drug of diuretics, it is spironolactone. The side effect again is erectile dysfunction and gynecomastia in males. It increases the potassium, hyperkalemia. So with this, the kidney topic is over. Now, coming to cardiovascular. Cardiovascular system is very, very important in pharmacology as well as in medicine. So this is correlating with your medicine also. What are the drugs? We can use ACE inhibitors or angiotensin receptor blockers. So ARB or ACE inhibitors, both these drugs we can use. What are ACE inhibitors? The drugs which end with pril, like captopril, eosinopril. All these drugs which end with pril are ACE inhibitors. All the drugs which end with certain, like losartan, valsartan, all the drugs which end with certains are angiotensin receptor blockers. Now, this losartan is specifically important because it is also an antiplatelet drug. It inhibits the thromboxane A2 receptor, so it is an antiplatelet drug. Another example is telmisartan. Telmisartan is used for diabetes mellitus. It is an anti-diabetic mellitus drug because it increases the PPAR gamma receptor. Also, telmisartan has 100% liver metabolism. Telmisartan has 100% liver metabolism, so it can be used in patients with chronic kidney disease. In CKD patients, you can use telmisartan. It is safe in CKD patients. So, angiotensin receptor blockers and ACE inhibitors are the first line for maintenance treatment of hypertension. It is the first line drug for hypertension. It is used in the treatment of CHF because it prevents cardiac remodeling, so it decreases the mortality in a patient. It increases the survival chance in a patient. So if in a MCQ it comes, what are the drugs which increases the survival chance, or what are the drugs which decreases the mortality in cardiovascular patient? It is ACE inhibitors and angiotensin receptor blockers. Now, the first choice for cardiac remodeling, to prevent cardiac remodeling or to decrease mortality, is ARNI. ARNI is a special group of drugs, is a new group of drugs. It is a combination of ARB, angiotensin receptor blockers, and neprilysin inhibitors. So, it inhibits the neprilysin, and the drug name, like it's angiotensin receptor blocker. So valsartan you can combine with neprilysin inhibitors. The drug name for that is sacubitril. So valsartan plus sacubitril is an ARNI drug. So the first choice will be ARNI, the second will be SCA inhibitors, and the third will be angiotensin receptor blockers if you need to decrease the mortality in a patient with CIG. Also, it is the drug of choice for diabetic nephropathy. Now, all angiotensin receptor blockers and ARBs are prodrugs except captopril and lisinopril. So, captopril and lisinopril are not prodrugs, they are given in active form. What are the side effects of SCA inhibitors and angiotensin receptor blockers? The side effects are cough and angioedema. It is mainly in SCA inhibitors, not seen in ARBs. Why cough and angioedema occurs? Due to increased bradykinin accumulation inside our body. The other side effects are hyperkalemia, taste changes, or orthostatic hypotension. In what conditions we cannot give these drugs? We cannot give in bilateral renal artery stenosis. In unilateral we can give, but in bilateral we cannot give. Pregnancy, and if the serum creatinine level rises above 2.5, so here we cannot give. Now, the second group of drug is renin inhibitor, which is a direct inhibitor of renin. In the name only you can find REN, so the name is aliskiren. So it is a direct renin inhibitor, and thus it helps in reducing hypertension and cardiovascular effects. Other name is digoxin. This is another drug. It is a sodium potassium ATPase enzyme inhibitor, and also it stimulates the vagal nerve. The vagal nerve stimulation also occurs. The main mechanism of action is sodium potassium ATPase enzyme inhibitor. It is used in the treatment of chronic heart failure, congestive heart failure, and if digoxin toxicity occurs, it can result in arrhythmia. So if digoxin toxicity occurs, it can result in arrhythmia, and how you can control that? The antidote is digiband. So by giving digiband, you can control digoxin toxicity. Also, why digoxin toxicity occurs? What are the risk factors? If there is any electrolyte imbalance like increased calcium, magnesium, or potassium, if any electrolyte imbalance is there, it can result in digoxin toxicity. If there is CKD, or if there is hyper or hypothyroidism, any thyroid problems, this can lead to digoxin toxicity. Now, coming to our next topic, which is hematology. So hematology drugs, we can divide it into antiplatelet drugs, anticoagulant drugs, and thrombolytics. So antiplatelet, there are 4 important drugs: aspirin, clopidogrel, prasugrel, apixaban, and dipyridamole. So first, coming to aspirin. Aspirin, we always have to give it in low dose. Low dose is preferred. The dose is 75 to 325 milligram. Aspirin, the mechanism of action is it blocks the COX-1 receptors, and therefore it decreases the thromboxane A2 synthesis. Now, coming to clopidogrel. Clopidogrel is an enzyme, requires an enzyme known as CYP2C19 for its metabolism. So this is an important question. CYP2C19, the enzyme name is important. What clopidogrel requires for metabolism? The other drugs are prasugrel and ticlopidine. What it does? What is the mechanism of action? It inhibits the P2Y12 receptors. Now, coming to another drug, abiciximab. It is a monoclonal antibody, and it inhibits the GP2B or 3A receptors. Now, coming to the GP2B or 3A receptors. Coming to the fourth drug, dipyridamole. Dipyridamole side effect, it causes coronary steal phenomena. It is again an important question. So, dipyridamole side effect is it causes coronary steal phenomena. The second group of drug is anticoagulants. Anticoagulants can be directly acting or indirectly acting. So, first coming to directly acting drugs can be divided into 2 groups. The one which blocks the 10A and the other which blocks 2A. So 10A blockers are apixaban. You can find it in the name only, 10A ban. So it blocks 10A apixaban and rivaroxaban, 10A ban. So you can, in the name only you can understand. And the other 2A blockers are direct thrombin blockers. The 2 is also known as thrombin. So these are direct thrombin blockers. Which are the drugs? Dabigatran or argatroban. So these are the drugs. Dabigatran is important. You can remember dabigatran and apixaban, rivaroxaban. Now coming to the indirectly acting drugs. What are the indirectly acting drugs? The first one is low molecular weight heparin. It is given in intravenous or subcutaneous route. So low molecular weight heparin example is enoxaparin, and it blocks both 2A and 10A. Here it was blocking 10A or 2A either. Here it's blocking both 10A and 2A. The antidote for enoxaparin toxicity is protamine sulfate. If there is toxicity, we can give antidote protamine sulfate, and it is safe in pregnancy. Low molecular weight heparin is safe in pregnancy. Coming to the oral drug warfarin. Warfarin blocks 2, 7, 9 and 10. It blocks all these factors, and when we give warfarin in a patient, we have to monitor it by using INR. By INR, we have to maintain warfarin levels. And the antidote for warfarin toxicity is vitamin K1. Now the third group of drugs are thrombolytics, which are also known as fibrinolytics. The examples are streptokinase, selective and retaplase. What does it does? It increases the tissue plasminogen activator. Therefore, due to increase in the tissue plasminogen activator, the level of plasmin will increase. It will ultimately result in the formation of plasminogen and thus plasmin, which will help in dissolve of clots. So thrombolytics main function is dissolve clots. Now, these drugs are used in the treatment of ST elevated MI and stroke. These patients we can use these drugs. Streptokinase is the first line treatment for stroke. Antidote, if toxicity occurs, antidote is epsilon aminocaproic acid and tranexamic acid. These are the antidotes for thrombolytics. Now, coming to our next topic, which are hypolipidemic drugs. Lipid means cholesterol, LDL, triglyceride, everything. So how to lower those? We can divide it into again two groups. The one which decreases cholesterol or LDL, the other which decreases triglycerides or VLDL. So first let's understand triglycerides. So the drug of choice for triglyceride lowering is fibrates. Example is fenofibrate. What does it does? The mechanism of action is it increases the PPAR alpha receptor and ultimately it works by increasing lipoprotein lipase enzyme. Now coming to the drugs which lower cholesterol or LDL. So cholesterol is lowered by statins. The mechanism of action is it inhibits HMG-CoA reductase. The examples are rosuvastatin or atorvastatin. What are the side effects of rosuvastatin, atorvastatin? These drugs, it causes hepatotoxicity, it causes myopathy like muscle loss of muscle tone, and it also causes hyperglycemia. Hyperglycemia is an important side effect. Rosuvastatin, atorvastatin, all statins are recommended to be given at bedtime at night after dinner. This works more at night time. The other group of drugs is PCSK9 inhibitors. Example is evolocumab. It ultimately blocks the cholesterol uptake. It acts by blocking cholesterol uptake, evolocumab. And the third group of drug is if by giving statin also it doesn't work, then we have to give the ultimate drug, which is ezetimibe. This is another group of drug. Now coming to a short topic, iron toxicology. So if there is toxicity of iron inside our body and if the patient is symptomatic, then the drug which we can give as an antidote is IV desferoxamine. IV desferoxamine if the patient is symptomatic. If the patient is asymptomatic, we can give oral deferiprone. If the patient is asymptomatic, oral deferiprone. If the patient is symptomatic, IV desferoxamine. These are iron chelating agents. Now, coming to antiemetics. Emetics means vomiting. So, antiemetics, to prevent vomiting, we give these drugs. Now, what is the most important type of vomiting which is important for your exams? So, chemotherapy induced nausea and vomiting. Maximum it happens with anti-cancer drug cisplatin. So due to after giving cisplatin, there can be chemotherapy induced vomiting. So if the vomiting, we can divide the vomiting also into two types. If the vomiting occurs less than 24 hours, we can call it as early vomiting. If the vomiting occurs after 24 hours, we can call it as delayed vomiting. Now in early vomiting, we can give 5-HT3 blockers. The drug of choice is 5-HT3 blockers. The drugs are ondansetron and palanosetron. All the cetron drugs are given for early vomiting. For late vomiting, the drug of choice is substance P inhibitors. The name is aprepitant. It is a substance P inhibitor. The other drugs are dexamethasone and olanzapine. These are the other drugs, aprepitant, dexamethasone, olanzapine. We can give it in late vomiting. And all the cetron drugs, ondansetron like palanosetron, cetron, if it is in the name, we need to give it for early vomiting, chemotherapy-induced vomiting due to cisplatin. Now, what are the other vomiting types? It will be morning sickness. So in morning sickness, we have to give doxylamine and we can combine it with vitamin B6. For motion sickness, we can give hyoscine and most important is promethazine. Hyoscine is given first. If it doesn't work, we can give promethazine. It is another drug. And also dopamine receptor antagonist. Dopamine receptor antagonists are domperidone and metoclopramide. Metoclopramide crosses blood-brain barrier, so it can cause Parkinson's-like symptoms like bradykinesia, rigidity. So it can cause Parkinson's-like symptoms because it crosses blood-brain barrier. Now, the most important topic, general pharmacology. So let's start with general pharmacology. Important one is clinical trials. Questions have already come many times from clinical trials. So what are the phases of clinical trials? 1, 2, 3 and 4. There are 4 phases of clinical trials. The first phase is also known as safety study, where we have to keep normal human volunteers and we calculate the maximum tolerated dose. So it is an experimental phase. We have to keep normal human volunteers and we calculate the maximum tolerated dose for a drug. Phase 2, here patients are admitted. The actual patients are admitted, not the normal human beings, and we calculate the therapeutic dose, like how is the patient responding to that particular amount of dose or drug. And in this dose, I am highlighting an important point. The maximum risk of drug failure happens in phase 2 of clinical trials, maximum risk of drug failure. Now coming to phase 3, it is a multi-centric trial. There are maximum number of patients in this phase and we have to do comparison of two drugs. It is the best phase for all the parameters, for all the pharmacokinetic or pharmacodynamic parameters. If you want to calculate, phase 3 clinical trial is the best phase, and the drug which is after phase 3 of clinical trials, after completion we can launch the drug in the market. After launching we have to do phase 4 clinical trials. This phase is also known as post-marketing surveillance. After launching in the market we can do this trial. Now here are two graphs. This is known as log DRC, y-axis, x-axis. Now what does this x-axis means? The x-axis means the potency of the drug, the y-axis means the efficacy of the drug. So if the medicine DRC, now after plotting on the graph, if the medicine DRC is on the left side of this line, so it is considered more potent. For example, in this graph you can find there are three drugs A, B and C. So the drug which is more on the left side, as you can find, compared to B, A is on the left side, so it is more potent. Then B is more left to the C, so B is next potent. A, B, C. According to potency, this is arranged. Now y-axis, so y-axis represents efficacy of the drug. So more the height of the line, more the height of the graph, the more efficacy the drug is. Here you can find A has more height, maximum height, so A is the most efficacious, B is less than A, B is less efficacious. So accordingly we can plot. Also another importance for this log DRC graph is we can calculate the therapeutic index. Therapeutic index is necessary to understand the drug safety. Okay, so what is the formula for therapeutic index? The therapeutic index formula is LD50 upon ED50, LD50 by ED50. Now what does LD50 means? LD50 means the dose at which 50% mortality is observed when we do animal trials, animal experiments. The dose at which 50% mortality, 50% patients or animals die. What is ED50? The dose at which 50% samples respond to the treatment, the dose at which patients or animals are responding to the treatment is known as ED50. LD50 is the dose at which patients are dying, 50% patients mortality is observed. Now let's understand what is competitive and non-competitive. So the right side shift, this is a drug A, and after taking another drug, the drug A has shifted to right side. So if there is right side shift, it is known as competitive. And this is drug A. The drug A has become more flat, the curve has become more flat. If it becomes flat, it is known as non-competitive inhibition. Now coming to another drug which is known as tolerance. In the drug only you can understand, first the drug was responding well, but after taking for a long period of time it has gone down, so the patient is now tolerated to the drug. Now coming to various type of receptors. So receptors we can divide it into nuclear receptors, cytoplasmic receptors, membrane receptors which act inside the membrane with associated with kinase activity, and the last one is membrane receptors associated with G protein coupled receptor, GPCR. So these are the four types of receptors. Nuclear receptors are mainly thyroid, vitamin A, PPAR and estrogen. So you can remember it by the mnemonic TAPE, TAPE, thyroid, T for thyroid, A for vitamin A, P for PPAR and E for estrogen. Coming to cytoplasmic receptors, all steroidal drugs. Example prednisolone, which is an example of glucocorticoids or steroids. So all steroidal drugs are example of cytoplasmic receptors, and vitamin D is also example of cytoplasmic receptors. Membrane receptors with kinase activity. What are these? You can remember this by the mnemonic PIG. So prolactin, insulin and growth hormone or growth receptors. So PIG receptors, prolactin, insulin, growth hormone or growth hormone associated receptors. Sorry. The fourth one is membrane, the drugs which act inside the membrane receptors associated with G protein coupled receptor. Now this G protein is 7 helical shape, and all the other drugs except these drugs, all the other drugs are membrane receptors associated with GPCR. This G protein is a G alpha protein and it is present. So what are the G alpha proteins? What are the types? G alpha S, G alpha I, G alpha Q or 0. So G alpha S, what is the function? It increases the CAMP, cyclic AMP. G alpha I, what is the work? It decreases the CAMP, and G alpha Q or 0, the function is it increases IP3 or DAG. So these are the type of receptors. With this we end the topic of general pharmacology. Now coming to autocoids. So autocoids, mainly the most important topic here is gout. So if a patient with acute symptoms, the drug of choice should be NSAIDs. We do not prefer aspirin in this case. We will prefer diclofenac as an NSAID, and we can give steroids or we can give colchicine. What is the maintenance treatment of gout? Maintenance treatment, Either we can inhibit the uric acid synthesis or we can increase the uric acid elimination from our body. So drugs which inhibit the uric acid synthesis are xanthine oxidase inhibitors. So xanthine oxidase inhibitors, the best drug is allopurinol, the drug of choice is allopurinol, the other drug is febuxostat. Which drug increases the uric acid elimination from our body? It is probenecid or losartan. So probenecid or losartan, it increases the uric acid elimination. Now coming to anti-cancer drugs, you may expect one MCQ from anti-cancer drugs, and we have already discussed the side effect of anti-cancer drugs, mainly of cisplatin, is chemotherapy induced nausea and vomiting. Also the other side effects are bone marrow suppression. What it happens? It decreases the number of WBC and decreases the number of platelets. So what we have to do, how we can treat the decreased number of RBC? We can give filgrastim. So filgrastim is a granulocyte stimulator. It will increase the number of WBC to counteract the side effect of anti-cancer drugs. And when the platelet decreases, we can give oprelvicane. It is an interleukin 11 analog and it increases the number of platelets. Another side effect of anti-cancer drug is tumor lysis syndrome. What happens in tumor lysis syndrome? There is increased uric acid production in our body. And how we can prevent this? We can prevent by using allopurinol, which we already discussed in gout. And the other treatment is rasburicase and pegloticase. These are the other drugs for treatment of tumor lysis syndrome. Rasburicase, pegloticase. The other side effects is methotrexate. Methotrexate is an anti-cancer drug. Methotrexate toxicity. How we can prevent methotrexate toxicity? We can prevent it by giving leucovorin. It is a folinic acid. And the treatment is forced alkaline diuresis. Leucovorin is for prevention. Treatment is forced alkaline diuresis. By giving diuresis, by giving alkaline diuresis, by removing it from the body only, we can treat it. Now, an anti-cancer drug, important is cyclophosphamide. It can cause hemorrhagic cystitis. Cyclophosphamide or ifosfamide, these drugs as a side effect can cause hemorrhagic cystitis. And how we can prevent it? We can prevent this by giving another drug which is known as Mesna, MESNA, Mesna. So to prevent hemorrhagic cystitis, we can give Mesna. Now, so our next topic is endocrine. Endocrine main includes anti-diabetic and hyperthyroidism. So what are the anti-diabetic drugs? It includes insulin, insulin secretagogues, metformin, and the drugs which increase glucose elimination. So first coming to insulin, what are the examples of long-acting insulin? Degludec and glargine. What are examples of insulin secretagogues? Insulin secretagogues, the function is secretagogue analog type. So it increases the insulin secretion inside our body, and it does by either acting on GLP. So it is GLP-1 analog. The example is liraglutide. So glutides are examples of GLP-1 analog. The treatment, it is also liraglutide is also preferred in treatment of obesity. The side effect for this is pancreatitis. The other group of drug is DPP-4 inhibitors, and it also increases GLP. The drugs example are gliptins like linagliptin, sitagliptin. So all gliptins drugs are DPP-4 inhibitors. Glutide drugs are GLP-1 analogs. And it also, like linagliptin or gliptins, all gliptins drugs, liver metabolism occurs, so it is safe in CKD patients. Now coming to metformin, it decreases the insulin resistance. It is the drug of choice for type 2 diabetes mellitus, and the side effect is it causes vitamin B12 deficiency or it causes lactic acidosis. Now coming to the last one, it increases glucose elimination by SGLT2 blockers. The examples are gliflozin. All drugs which ends with gliflozin are SGLT2 inhibitors. Example, canagliflozin. The side effect for this is since it eliminates it causes glucose elimination from our body. So in our urine also glucose is present. In this case, it causes UTI and vulvovaginitis in females, and in males it can cause Fournier's gangrene. Fournier's gangrene you can study from surgery. Now coming to the next topic in anti-diabetic drugs, endocrine drugs, it is hyperthyroidism. So how we can control hyperthyroidism? We can control that by either decreasing the hormone synthesis or blocking the hormone release or blocking the conversion from T4 to T3. So by these three ways we can control hyperthyroidism. Now, which drugs decrease hormone synthesis? Carbimazole. It is a drug of choice for maintenance treatment of Graves' disease or hyperthyroidism. It is a drug of choice in pregnancy in second and third trimester only. It is contraindicated in first trimester because it can cause aplasia cutis of the baby. What is the side effect? The side effect is agranulocytosis. Now another drug is propylthyrosol, or short form is PTU. It is the drug of choice for pregnancy in first trimester. It is also the drug of choice for thyroid toxicosis. The side effect is hepatotoxicity. Now the other group of drugs which inhibit the hormone release, it can be iodides like leugolside in sodium iodide or potassium iodide. And there are drugs which block the conversion of T4 to T3. So with this we end the endocrine system. Now SERM, selective estrogen receptor modulators. So all the drugs which end with fen, FEN, are selective estrogen receptor modulators. Example is tamoxifen. This is the most important drug. Sorry. It is used in the treatment and prevention of breast cancer, and the side effects are cataract, endometrial cancer, and thromboembolism. The other drug example is ormanexifen. So it ends with fen, it ends with fen. All the fen drugs are SERM. And the example is ormanexifen are Saheli and Chaya. You have studied it in gynecology. These are used as OCPs, oral contraceptive pills. Another example is raloxifene, again fen. It is an estrogen receptor analog, and it is used in the treatment of postmenopausal osteoporosis. So in the postmenopausal phase, the level of estrogen decreases inside our body, which can cause osteoporosis. This drug, raloxifene, it will act as a estrogen receptor analog and helps the estrogen receptor to secrete more estrogen. Clomiphene, it is used for ovulation. It is used for ovulation. What is the side effect? It causes multiple ovulation, which can result in multiple pregnancy. So multiple ovulation. Now, what is the drug of choice for ovulation in PCOD female? The drug of choice for ovulation is always letrozole, not clomiphene. The drug of choice for ovulation in PCOD female is letrozole, because in PCOD we have to do aromatase inhibitors. So letrozole is an aromatase inhibitor. Now, coming to antiviral drugs. So antiviral drugs, the most important one is HIV. We can give NRTI, which is nucleoside reverse transcriptase inhibitors, NRTI. The examples are lamivudine or zerovudine. The drugs which end with vudine, VUDINE, are NRTIs. Another drug is NNRTI, which means non-nucleoside reverse transcriptase inhibitors. Example is efavirenz or neviparin. Integrase inhibitors, example is dolutegravir. So drugs which end with gravir, dolutegravir. Protease inhibitors, drugs which end with navir. Here it ends with gravir are integrase inhibitors. The drugs which end with navir are protease inhibitors. What is the treatment of HIV? The treatment is lamivudine plus dolutegravir plus tenofovir. These three drugs in combination is used in the treatment of all HIV patients. Lamivudine, dolutegravir, or tenofovir. Another important viral disease is swine flu, H1N1 or H3N2. The treatment is oseltamivir. It is a neuroamidase inhibitor. Now, coming to antifungal drugs. The first one is liposomal amphotericin B. It is the drug of choice for three things: mucormycosis, which is also known as black fungus, cryptococcal meningitis, and visceral leishmaniasis, which is also known as Kala Ajar. So liposomal amphotericin B is the drug of choice for all these three things. Mucormycosis, you can refer to my derma video. Now, what are the side effects? Side effects is nephrotoxicity. It will lose magnesium and potassium ions. So ultimately it will cause neurotoxicity or ototoxicity. So these are the side effects. Another group of drugs is azoles. So drugs which end with azole, like fluconazole, itraconazole, or voriconazole. So azole drugs are also antifungal drugs. Fluconazole is a drug of choice for candidiasis. Itraconazole is a drug of choice for tinea or dermatophytes. You can study from derma video. And voriconazole is a drug of choice for invasive aspergillosis. So these are the drug of choice. It is very important to remember. Coming to anti-malarial drugs. So anti-malarial drugs, example is primaquine. It is used in the treatment of Plasmodium vivax. Plasmodium vivax group to control the relapse, and for Plasmodium falciparum to control the transmission. So primaquine is given. What is the contraindications for primaquine? We cannot give it in pregnancy and in patients who have G6PD deficiency. So you cannot give. Now, for malaria prophylaxis, you have to remember this. It is very important from your PSM point of view. Question will definitely come. So for malaria prophylaxis, if a traveler has visited to India and for less than 6 weeks the traveler has visited, you have to give doxycycline. And if the patient is, if the traveler is a pregnant or a child who is less than 7 to 8 years, we have to give proguanil. For less than 6 weeks, doxycycline. If it is pregnant or child less than 8 years, we have to give proguanil. For more than 6 weeks, we have to give mefloquine, and the side effects are neuropsychiatric symptoms. Now, what is the treatment of cerebral malaria? which is also known as black water fever. What is the treatment of cerebral malaria? We have to give artesunate, which is the drug of choice. It is the most preferred. Then we can give artemether. If it is not in the option, we can give quinine. So this is the preference order. Artesunate is the drug of choice. Now, coming to mycobacterial drugs, drugs we are give for mycobacterium. The most important ones are leprosy and TB. So leprosy regimen, you have to remember it very well. You can refer to my derma video for leprosy regimen. It is already discussed in derma video. And for TB, there are 3 drugs: H, isoniazid, rifampicin, pyrazinamide and ethambutol. H are JD group of drugs. So what are these drugs? First one is isoniazid. This is cell wall inhibitor. Rifampicin, also isoniazid, pyrazinamide and ethambutol, all are cell wall inhibitors. Only rifampicin is a RNA polymerase inhibitor. So you have to remember this. Now, what are the side effects of isoniazid? It causes hepatotoxicity. Hepatotoxicity is a common side effect of all the 3 drugs. Also, isoniazid causes neuropathy because it causes vitamin B6 deficiency. What is the side effect of rifampicin? It causes hepatotoxicity, hypersensitivity reaction because it causes myelosuppression, means bone marrow suppression. There can be orange discoloration of body secretions after taking rifampicin. And what is the side effect of pyrazinamide? It again causes hepatotoxicity and hyperuricemia. What is the side effect of ethambutol? It causes optic neuritis, hyperuricemia. Optic neuritis, the most common example is red-green color blindness. So red-green color blindness, if it is in the question, it is the side effect of ethambutol. So this is the most probable question to come from here. Okay, now all the drugs, isoniazid, rifampicin and pyrazinamide acts by bactericidal effect, whereas ethambutol only acts by bacteriostatic. It is the only drug in the TB group of drugs which acts by bacteriostatic. So rifampicin, apart from TB, we can give in leprosy and methicillin resistant staph aureus also, MRSA also. Now, what are the new drugs which are recommended for TB? Bedaquiline and delamanide. It is used in the treatment of MDR, multi-drug resistant or extreme drug resistant TB, MDR or XDR TB. Now, coming to our last topic, so 2 topics are left: anti-epileptic and antidepressants. So first, understand antidepressants. Antidepressants I have already studied, like I have already given in the psychiatry video. You can refer to psychiatric video for antidepressant drugs. And our last topic is anti-epileptic drugs. So anti-epileptic drugs are phenytoin, valproate, topiramate, lamotrigine and carbamazine. These are the main anti-epileptic drugs. So phenytoin, it causes vitamin D deficiency, vitamin K deficiency, vitamin B9 deficiency. All these are side effects. Okay, these are the side effects of the drugs, not the use. So what is the side effect? It also causes gum hypertrophy. What is the side effect of valproate? It causes hepatotoxicity, hyperaminuria, tremors or PCOD. What is the side effect of topiramate? It causes weight loss, metabolic acidosis or renal stones. Side effect of lamotrigine, it causes hypersensitivity reaction. Side effect of carbamazepine, it causes water retention or agranulocytosis. Now, this also I have taught it in psychiatry video. These are the various de-addiction regimens. So for opioid toxicity, what we can give? We can give naloxone. It is combined with your psychiatry. This question can come. Opioid toxicity, naloxone. For nicotine toxicity, we can give nicotine only. So skin patch nicotine, varenicline, this is another drug, or bupropion. These are the for nicotine toxicity. Nicotine means cigarette or tobacco. And for alcohol, we can give, for alcohol addiction, we can give naltrexone. So these are the 3 de-addiction things we have to remember. So I hope with this we cover all the important things of pharmacology. And if you study these 6 pages, it will hardly take you 1 hour of time. So just study this before going for the exam, and you are good to go. You can attempt at least 90% of the questions, and if your luck is good, you can attempt all the 100 questions. It is integrated with your medicine, psychiatry, derma, everything. So with this, we end the session of pharmacology. Please comment down your feedback, like how the video is helpful, if it is helpful or not, and what do you want to improve with my video, what do you want from me, what more you can want from me, you can mention in the comment box. The PDF link will be given in the comment box, it will be pinned, and also you can join my Telegram study group. And please subscribe to my channel. Thank you, have a good day, all the best for your exam.